everyone. Today I am going to do a case presentation on an essential thrombocythemia patient. So my case is about an 83-year-old man who is already diagnosed with essential thrombocythemia, and he has presented certain decline in hemoglobin levels in his previous assessments. So this raised the suspicion of iron deficiency anemia in him. So the doctor asked to administer intravenous iron therapy, and the results were evaluated after 6 weeks. So apart from non-ET, there is no clinical history or no symptoms are attached to this patient. This is a request form asked wherein he is asked to perform full blood count and iron studies as well as PSA. And this is the diagnostic findings of the patient from the whole blood. All the red cell parameters are here, and you can see this darkly black in color shows that these parameters have slight variation from the normal range. So these are the parameters that show slight variation from the normal range. For example, hemoglobin. If you see the hemoglobin from December 24 to March 25, after post infusion, this hemoglobin level has increased. That means his anemia has got corrected by giving iron. And MCH also, if you see these values, this shows there is hypochromia in him. So after giving iron, this value has improved. That means almost in the normal range, which indicates that this anemia, that hypochromia, is also got corrected by giving iron. So this is also improving, MCHC is also improving, and RDW, if you see, even though it increased a lot, it indicates that there is new RBC cells are forming, or reticulocytosis is happening there. That means new RBC cells are forming in that patient. As well as in the case of WCC, if you check, even though it is higher, it is getting lower. That means still there is mild leukocytosis is present, and neutrophils also mild neutrophilia is present, and basophils you can see persistently basophilia. And the platelets shows a steady increase from 595 to 605 to 643. That means there is persistent thrombocytosis in this patient. So if you check the parameters, these are the improvement parameters in this patient after giving iron therapy. You can see hemoglobin, then MCHC, MCH, WCC and neutrophil. And RDW, it is still high, which shows there is reticulocytosis or immature RBC cells in them. Then basophils, neutrophilia and WCC are high. That means there is myeloproliferation happening in that patient. And platelets are high, which indicates thrombocytosis. And differential consideration of this patient are, we know that basophilia leukocytosis is actually indicating myeloproliferation, and there is different kinds of myeloproliferative diseases. And CML is the one of the most important myeloproliferative disease. So whenever such a case happens, doctor initially asks to detect the BCR-ABL translocation to rule out the CML, to check whether the CML is present or not. Then she will go for the other, she or he will go for the other diagnosis. So bone marrow biopsy will help to determine which is the actual problem in that patient. So causes of thrombocytosis. So we saw that this patient has got persistent thrombocytosis. There is two reasons for thrombocytosis, either primary or secondary. Primary means due to some acquired mutations, like in the case of essential thrombocythemia or primary myelofibrosis or polycythemia vera. These are occur due to primary mutations. And in the case of secondary one, this is due to some kind of underlying conditions like either iron deficiency anemia or kind of infection, due to some post-splenectomy or inflammation, something like that. So this patient, when we check, he has a history of ET. So this thrombocytosis is mainly because of his ET. And there is iron deficiency anemia also detected in this patient because he has got reduced hemoglobin level, which was increased after iron therapy. That means there was iron deficiency anemia, which was corrected by giving iron in this patient. So these two are there present in this patient. So this iron deficiency anemia also transiently increase the platelet count in this patient. So this patient majorly has essential thrombocythemia. So what is actually essential thrombocythemia? It is actually a myeloproliferative disorder which has got megakaryocyte, hyperplasia with hyperlobulated nuclei, and this occurs due to a clonal abnormality in the hematopoietic stem cells, in the myeloid stem cells. So if you see the bone marrow aspirate of this EP patient, you can see atypical megakaryocytes, and it has large number of nuclei which are hyperlobulated. And if you see the blood film of this patient, you can see a lot of platelet aggregates, that means increased thrombocytosis. So this is again another picture showing a staining picture of bone marrow showing occasional clumps of these megakaryocytes and the hyperlobulation. So epidemiology, this occur in around 1 to 2 patients in 1 lakh of people. So it is mainly found in female patients and it is very rare in children, and usually it is diagnosed at the age of 60 years. So the major reason for having ET is genetic mutations, mainly 3 mutations. They are Jagannath Ganga, especially in the 6-month 7 position where valine is converted to phenylalanine. Due to this mutation, this ET occurred around 50 to 60% of people. Then next possible mutation is reticulin. It is actually a gene, this is calcium regulating gene, which is also when mutated, which cause around 30% of this disease. Then myeloproliferative leukemia virus oncogene, MPL gene, which is the gene coding for thrombopoietin receptor. So if there is a mutation in this gene, it will cause the overproliferation of thrombopoietin receptor and ligand independent activation, which will result again in the disease. So this is the pathophysiology. Jagannath is a protein kinase in the JAK-STAT pathway, which is involved in the proliferation and differentiation of megakaryocytes. Any mutation means uncontrolled proliferation occurs, and reticulin is actually a gene involved in the calcium regulation. What it will do is when mutated, it will mimic thrombopoietin binding to its receptor, and continuous activation of megakaryocytes happens, or platelet production happens. Then again, this is a thrombopoietin receptor gene. The mutation happens in this position, 515, and continuous or ligand independent activation occurs, and what happens is continuous proliferation of megakaryocytes in the bone marrow and hyperplasia of the megakaryocytes occur there. So based on all these features, the WHO has designed a diagnostic criteria for ET, because ET and several other myeloproliferative disorders share many common features. So in order to distinguish that ET from other myeloproliferative disorders, they have designed a diagnostic criteria. And these diagnostic criteria involve 4 major criteria and 1 minor criteria. Either 4 major or 3 major plus 1 minor criteria is followed, means the patient has ET. For example, the platelet count should be around more than 450 into 10 raised to 9 per liter. It should be greater than that. And the bone marrow biopsy, when done, it should show hyperplasia of the megakaryocytes with hyperlobulated nuclei. And there should not be any kind of BCR ABL1 mutation or any other kind of mutation related to the CML, or PMR, or any other myeloid neoplasm. And either one of the mutation from JAK2 or CALR or MPL should be there. And the minor criteria is the presence of any other kind of subclonal markers. For example, in certain cases of ET, there is triple negative cases. Triple negative means 3 of this mutation is not present, but some other subclonal mutation in some other genes is present, but it is very rare. And either the presence of such clonal marker or absence of reactive thrombocytosis due to some underlying conditions. If these criteria are met, that means that patient has ET. So this patient, or my case study patient, has got ET, means he is satisfying all these patients, all these criteria. So in most of the cases, the patients are asymptomatic. They don't have much symptoms, but they do have a great risk of thrombosis And some patients have great risk of hemorrhage, especially when acquired bone brand disorder happens in them because of extreme thrombocytosis. Or some patients have splenomegaly or vasomotor symptoms like erythromyalgia, headache and all will happen in this patient, mostly asymptomatic. So if you see the laboratory findings of these patients having ET, you can see in the full blood count there is sustained elevation in the platelet count, then mild leukocytosis you can find. If you see the blood smear, you can find platelet aggregates, giant platelets, some megakaryocyte fragments also. Then in this case, coagulation profile, PT and APTD is normal because it is not affecting any coagulation factors. And bone marrow biopsy, if you check, as I already said, it will be hypercellular, it will have giant megakaryocytes and hyperlobulated nuclei. And if to specifically identify this kind of hypercellularity, we can use IHC stain. For example, CD61 is a specific marker of platelet. So it will identify the megakaryocytes and its cluster form in when done IHC. And this is a major important test, that is the genetic and molecular test. Only when this is conducted we can define that the patient has that is either J kinase 2, CALR or MPL mutation, and it should be ruled out. So since most of the myeloproliferative disorders like ET share many common factors, there is differential diagnosis is available for this one, that is chronic myeloid leukemia, because both the CML and ET has higher thrombocytosis. So first we have to rule out this fish. Then polycythemia vera, it also has JAK kinase 2 mutation and all. So we have to rule out that also. Then primary myelofibrosis. These kind of ET patients has got fibrosis also, then it may progress to myelofibrosis also. So we have to distinguish between them because these all share similar kind of mutations. Then reactive thrombocytosis, by detecting CRP or interleukin, that is acute phase reactant, we can rule out the chance of this kind of reactive thrombocytosis. So prognosis. This myeloproliferative disorder is an indolent one. It is a slowly progressing one disorder, and estimated median age of survival is around 18 years. They can lead a normal life, no much problem happens to them. And the patients who are diagnosed before 60, they have a good life expectancy, about 33 years of age. And the higher risk for these patients are thrombotic risk, and the International Prognostic System has actually given ratings for ratings based on this risk using genetic information and clinical factors. For example, in the case of EC, for thrombosis, the risk is like this. 0 to 1 is the point given for low risk patient, and 2 to 5 is the point given for intermediate, and 6 or more for high risk patients. That is, very low means they don't have any prior thrombosis, or the age is less than 60 and they don't have this mutation, JAK2 mutation. And low risk patients is they also have no prior thrombosis and age is again less than 60 years, but JAK2 mutation is present. And intermediate, again no thrombosis, but age is higher than 60 plus JAK2 no mutated. Then high means thrombosis history is there, then age can be anything, any or maybe mostly 60 years above, and JAK2 is mutated. And WBC is also greater than 11 is 10 raised to 11. If you see in the initial slide, this patient has got higher WBC, but no other information except his age is given, so we cannot determine which is the risk category of this patient. So this myeloproliferative neoplasm, like the ET, can progress into different various other disorders like acute myeloid leukemia or myelodysplastic syndrome, because this not only this mutation they can gain, they will be exposed to several other mutants, and also the disease may progress into more dreadful one. then it can undergo delayed progression into fibrotic stage and become, that means it can undergo the bone marrow can undergo scarring, and finally it can lead to myelofibrosis also, post myelofibrosis. So treatment in aging patients based on the risk factors, especially the age, then risk factors like cardiovascular, then thrombosis, very important, then platelet count, and other markers of hypercoagulability and obesity. These are the different risk factors considered while giving treatment. And the major therapies are, first is observation. Very low risk patients are just observed. They are regularly monitored. No much treatment is given. Then the other major treatment is low dose aspirin. Then cytoreductive therapy using hydroxyurea, enalapril, interferon are given. Or in some cases, in the case of extreme thrombocytosis, platelet paralysis is done. So low dose aspirin, it can prevent thrombosis, mainly thrombosis. It can control vasomotor symptoms, it can reduce platelet count. Similarly, hydroxyurea. Hydroxyurea is the most preferred cytoreductive agent. It can reduce platelet count, it can control thrombosis. Then enalapril, it can also be used, but it has got a cardiac toxicity. It acts as an inhibitor of certain diasterase enzyme in the wall of the blood vessels. So it may cause tachycardia. So it has got cardiac toxicity. So it is limited use. Then PET interferon is polyethylene glycolated interferon. This is used added because it increases the shelf life or the half-life of this interferon, and it can reduce platelet and thrombotic resistance again. So I told you that the platelet count is extremely high. It means more than 1,809 per liter means there is a chance of acquired bone membrane disorder. So the platelet paralysis is immediately performed to remove the platelets. So platelets. And in low risk, in the case of pregnancy patients which have very low risk, normal observation and low dose aspirin is enough. And in high risk and intermediate risk patients, heparin and interferon is given. Aspirin is avoided because it may cause bleeding in the later stages of the pregnancy. So this is how the treatment is given. For very low risk disease, that means no history of thrombosis, age which is less than 60 years, and mutation, JAK2 wild type is present, no cardiovascular risk, and triple negative, only observation, just daily observation. If there is a kind of cardiovascular risk factors or any kind of this kind of mutation, once daily aspirin is given. Then in low risk disease, again no history of thrombosis, age less than or equal to 16 years, and JAK2 mutated, and no cardiovascular risk, once or twice daily aspirin is given, and cardiovascular risk factors is present, twice daily aspirin. Then intermediate risk disease, no history of thrombosis, again these parameters, age greater than 60, then cardiovascular risk factors absolute, twice daily aspirin. Then cardiovascular risk present is hydroxyurea. Then again, this is a high risk one, history of thrombosis, age greater than 60 years with JAK2 mutation. It can be distribution to arterial thrombosis and venous thrombosis history, hydroxyurea plus twice daily aspirin, or hydroxyurea plus systemic anticoagulant. And JAK2 mutated or cardiovascular risk factors present, consider as once daily aspirin. This is a treatment given, but these differs according to the individual. The conditions present in the individual, the symptoms present in individual, the treatment options varies. So in this patient, what we need is, we have already found that his previous assessment showed reduction in hemoglobin level, after which when iron therapy is given, it improved. Similarly, regularly this cell blood count, CBC should be regularly monitored, and to determine, and iron study should be done to determine whether this can any kind of secondary thrombocytosis or any other kind of risk are happening in these patients, or any treatment should be given, any modification in the treatment should be given. So regular monitoring is the important thing that should be given in this case, in these kinds of patients. So earlier it was RBW was lower. So now we have to regularly monitor to determine whether it is getting normalized or not. Then if this patient, once it is improved, sometimes after some days or some weeks, that may again decline. So it should be checked whether the person should be given iron therapy again or not. Then spleen should be considered because splenomegaly is a major chance. So spleen should be monitored. Then bone marrow biopsy should be done regularly, not regularly, once in a while, because if there is a major change in blood counts, there may be some problems happening in the bone marrow. Some minor progression may be happening. So we have to check do the bone marrow biopsy in these patients once in a while. So major thing is that this patient should be continuously monitored at possible of 1 or 3 months interval to determine any changes is happening in this hematological parameters. So this is about my case study of evaluating hematological parameters in an essential thrombocythemia patient. Thank you.